And now let's turn our focus to something deeply relevant, timely and global, oral health as a reflection of total health. Our next session, which dives into one of the most critical discussions in contemporary dentistry. From cardiovascular conditions and diabetes to quality of life and mental well-being, oral health is intertwined with every dimension of human health, and yet it remains one of the most underdiagnosed and under-discussed disease, especially in developing countries like ours. So this session brings together a truly global panel of thought leaders, clinicians, educators, and researchers to explore how we can bridge the gap between knowledge, awareness, and action. For the panel discussion, I would like to invite our speakers. Dr. Yong Chong Chen, Chief Division of Prosthodontics, National Cheng Kung University and Hospital from Taiwan. Can we please have Dr. Chen on stage, and let's welcome him with a round of applause. Dr. Nitin Bhagat, Professor, Oral and Maxillofacial Surgery at Manav Rachna Dental College. So please join us on stage. Dr. Major Chandra Prakash, Maxillofacial Surgeon and Oral Implantologist at Curative Dental and Implant Center. Thank you so much for joining, sir. Dr. Omkar Shetty, Dean and Professor, Faculty of Dental at SDT University, Gurugram. Thank you so much for joining in, sir. And now to moderate and guide this discussion, I would like to invite Professor Monica Arora, Vice President at Research and Health Promotion Division, Public Health Foundation of India. Thank you so much for joining, ma'am. Over to you now.
Thank you. At the outset, I would like to start with a disclaimer. I am not a dentist. So, if somebody is disappointed, I would just like to mention what I do with oral health. So, I am a public health scientist, but my specialization in health promotion makes me eligible to work on all health issues that impact the population. So, I am in oral health. And I became interested because I work in non-communicable diseases, and I see a very integral connection between NCDs and oral health, and as we all know, the evidence is eminently clear. So, to begin this session, and the theme that has been given to us is very appropriate, and I would like to thank the Voice of Healthcare for dedicating this platform to such profound theme which is relevant for global and national priorities. Rethinking oral health, global trends, systemic links, and the fight against oral cancer. So, shifting gears a bit, for too long we all know oral health has been a separate clinical silo. It's only now that we all are starting to see how it is relevant for overall health and well-being, and also the fact that oral cancer is a condition which is relevant for South Asia and particularly for India because of the burden and the number of cases that all of you in the room see daily and treat, and you know the debilitating situation of the patients when they come with very advanced cancer. We are also here today to look at the global consensus and affirm that oral health is a non-negotiable component of systemic health. So the need for this integration has not only become relevant in India, but all of you may know where it was very clearly mentioned that oral health is a major health and economic burden which impacts people throughout their lifetimes. These are largely preventable, and the strategies are integrated for prevention in the primary health care and universal health coverage. So we would like to today emphasize on these two aspects with the panelists we have here with us. Also, I would like to point out the earlier speaker, Dr. Awasthi, did point out that there is not enough research that is happening in oral health. So Indian Council of Medical Research has invested created a national health research priority project called Anand Muskan. It is a multi-site oral health promotion intervention. It's an implementation research. I'm the principal investigator of this in Delhi. So all the schools in Northwest District of Delhi have been brought under the program where teachers have been trained to become instructors for daily toothbrushing in schools. And also oral health education, screening is being done, DMFT, OHIS scores are being calculated, reference being made. So such initiatives will go a long way into understanding how these case study sites will come up with a model that can then be scaled up at the national level under the National Oral Health Program. And talking about cancers, oral cancers are a priority for screening under the National Program for NCD prevention and control. And we all know that there are training guidelines for health workers to be able to use visual techniques to be able to identify precancerous lesions and advanced screening in that direction. So one point that I would like to emphasize and discuss today is that oral potentially malignant disorders, whether it is leukopenia, retroplakia, or ONP, all of these have a very long frame. It takes many years for the condition to become malignant. So that is where early detection plays a very important prevention role, and also treatment can be much more effective without being a burden on the health system and the families. So I will now hand it over to Dr. Oka Shetty for moderating this session. Unfortunately, I have to leave because I had appointed for another meeting, but it's a pleasure to be hearing from the stalwarts of dentistry today, and thank you so much, and apologies that I have to leave in the middle of the session. Over to you, Dr. Shetty.
Thank you so much, Professor Arora. It was really insightful opening remarks to start this beautiful session. Thank you. So, taking over, I would first talk to Professor Chen. Professor Chen, Thailand has been at the forefront of integrating innovation in oral rehabilitation. How have the digital workflows and multidisciplinary coordination improved early detection, treatment, and post-surgical quality of life for surgical patients?
Well, hello everyone. I'm a prosthodontist, so basically I do all kinds of dentistry every day. So recently I met a patient that she had osteosarcoma on her maxilla. So she had like the hemi section. The half of her maxilla was cut off. So we have to find a way to reconstruct her face. Well, I've been doing the digital work for so many years. So before we decide to do the treatment, basically the first thing we have to discuss with the patients what kind of dentures that we want. And since she is very young, so she doesn't like the removable options. So she mentioned that I want something fixed. So in that way, the only thing we can do is like the OLX procedures, right? But in order to do that, you have to have enough sufficient bone quality and quantity. But since she had the osteosarcoma, so she had like she lost the major part of the maxilla. So what we have to do is to have the zygomatic implant in order to make this happen. And to do the planning, the the first thing that I will have to do is I basically do the facial scan and also the intraoral scan and combine all these two images, including the open CT, together, so that I can create markup dentures, trial dentures, so I can put that dentures in the mouse and to see how this mouse this denture can help to reconstruct the smile. And then after that, after the patient is satisfied with the appearance, then the next thing we have to do is to planning the position of the implants. And that will be easier because once you have the final shape of the final contour of the dental prosthesis, then it will be very easy to plan where we should put the implants. But to help the surgeons precisely put the implant into a place that the prosthontist wants, then we need to design some sort of the surgical guide for the surgeon. And in Taiwan, right now we have the method of 3D printing. So if you have been using the surgical guide, you must know that no matter how you make the surgical guide, sometimes you may use the 3D printing, and sometimes you may use the CAD technology to do your surgical guide. But it's plastic, and sometimes these plastic materials, it can deform, so that when sometimes even you do a very good the pre-surgical planning, the surgeon still cannot put the implant to the right positions. So in Taiwan right now, we have been doing is the 3D printing using the metal to do the surgical guide. And then because today I don't have the presentation slide, otherwise I can show you how you do this kind of surgical guide. And because this kind of surgical guide, basically you print the whole structure, and this structure can be the framework of the interim dentures for the patients. So it has like two functions. The first function is to help the surgeon to put the implants, and right after the surgery, you can reuse this surgical guide as the framework of the interim dentures. So right after the surgery, the patient can receive interim denture with a very good framework, and that provides the rigidity of the dentures. And so that's how I integrate the digital workflows into the reconstructive smile of the cancer patients. Yeah.
Thank you so much. Coming to Dr. Bhagat. Sir, from a surgical standpoint, how can India move from late-stage oral cancer management to proactive early detection, especially among high-risk and underserved populations?
Right. Good afternoon, everyone. I'm Dr. Nitin Bhagat, practicing maxfac surgery. So the point sir raised is, like now the patient, whenever we see a patient here in our OPD, the patient will come around like late stage. In India, the problem is the patient will always come at the late stage, not early stage. That's what we have to think about, that we should do the screening properly, make sure that screening should be done in the remote areas, and the root cause for these are lack of awareness in the people. They are not aware of the disease, what the small lesion can make it large at the late stage. So make sure that your lack of awareness should be, this one should be integrated. And next one is poor access. Then affordability is not there with the patients. So we should plan with the mobile screening vans in the remote areas. use of dental access, which we do normally in remote areas, which is not possible. So make sure we should do that. And next is use of AI screens. Very important. Use of AI screens nowadays. We should put it in the remote areas. We should give it good access for the patients who cannot afford this treatment. So because early detection is very important. And coming to the surgical point of view, so the patient comes late, then it causes disfigurement of the face, most common. Disfigurement is very common in the late stages. And one should exactly be referred to in any remote areas, if the dentist should be there, or can refer to ENT surgeon or a dental, and make sure that all the dentists should know how to do a biopsy. Very, very important. The biopsy should be the gold standard for the detection of the cancer patients. And according to surgical, then we have ASHA workers. We have to contact them, and we should make sure that they should know how to do a oral visual examination. Very, very important. Then make sure we should collaborate with the nutraceutical companies. We should have different medicines at remote centers to prevent the detection of the starting of the cancer, right? Yes. Thank you.
Thank you so much, sir. Coming to Dr. Prakash, as a practicing maxillofacial surgeon, how can private practitioners play a stronger role in early diagnosis and referral of suspected oral malignancies, and what systemic barriers hinder timely intervention?
I'll say not as a private practitioner, but we are the first healthcare professionals who sees the oral cavities on the first day. And when the patient comes to us, they come with some kind of dental issues. Maybe dental issues, but we'll have to find out whether this is the level where we'll have to find out that we have to detect the precancerous and the cancerous lesion in the routine dental checkups. With that, we have a very vital role. That patient is coming to us for any kind of treatment, but maybe they have a white lesions, they have an oral lesions. So it's our moral duty to rule out the things with the systematic investigations of the lips, the oral cavities, the vestibule, the dental part, the tongue, dorsum of the tongue, ventral surface of the tongue, the lateral part of the tongue. Is there any kind of the bite over there? Is there any kind of the floor, floor of the mouth issues, or any kind of cheek biting or traumatic chronic bite is there? If you find any kind of suspicious lesion, this is your duty, because most of the times we have seen that, in fact, more than 90% of the people, we are more oriented towards our dental issues, or maybe in a general dental practice, we are more turning towards an implant practice or some kind of a rehabilitation practice where we can earn more money. But these patients do have some other issues also, so we should have some kind of primary screening devices, optical imaging devices, some kind of salivary biomarkers, that we can do the screening there and then, in case if we found some kind of suspicious lesion. So we should have a referral system which makes us to make it more routine referral or an urgent referral. Because being a dentist, the maxillofacial surgeon or oral medicine specialist or any other specialization, we can refer the patient to the higher center with our remark on that, with our OPD also, that we have found some kind of the lesion. That lesion could be an urgent referral also. How can we make it a difference between a routine referral and an urgent referral? On the basis of brush biopsies, maybe some salivary biomarkers, and optical imaging devices like non-band imaging nowadays, OCT, that is optical coherence tomography, very, very good and very economic also. It's not very costly things. So we can go with that, because with that, even the slightest changes in the oral cavity can be addressed there and then, and we can refer the patient. Most of the cases are getting damaged because of the unawareness of the private practitioner, as well as considering wait and watch. Let's see, dekh lenge. Maybe after 2 weeks, and then we forget about the patient. We should have some kind of data that in case if we found a suspicious lesion, we should call those patients again after 1 or 2 weeks. And if the things are not resolving, we should send these patients to a higher center. Not resolving means in case if there is a kind of a ear pain which is not having any local cause, let's say. There is a unilateral sore throat, which is very common sometimes. That is also a part of carcinoma. If there is a white lesion or an oral lesion like erythroplakia or a leukoplakia, red and white lesions, where we can send the patients. If there is any kind of tooth mobility without any kind of periodontal disease, we consider that grade 3 tooth mobility. But what is only single tooth is mobile, or maybe 2 teeth are mobile, rest of the structures are perfectly fine. That means these are urgent referral cases. Rather than delaying it anymore, we should refer these cases to the higher center. If being as a private practitioner, we are not doing that. We are more into rehabilitation and the general dental problems, maybe oral surgery problem. But being as a specialist, we should refer these cases to the higher center at the earliest. There is a timely problem like this. Second, you asked that there is a hindrance in the systemic referral system. So we have a very inefficient referral system. We do not have resources to refer. But in inefficient referral system, we can make it more on the basis of routine and urgent referral, as I have already said. And the second thing is, sometimes patient does not come to us because of the fear, stigma, cultural barriers. And sometimes we are lack of aware, as well as our practice is not that much in that particular field, that we delay the cases unnecessarily. So we should more on the screening examination, which can be done on the chair side, like as I said, the markers and other things, or otherwise we can take the help of an oral surgeon or an oral medicine specialist. Nowadays easily available almost most of the centers in a private practice also. And then we can definitely make a change in the oral cancers, early intervention and their treatments. Thank you.
Thank you, Dr. Prakash. Dr. Chen, coming back to you. Is digital prosthodontics, AI-assisted design and 3D printing, which are transforming post-cancer rehabilitation, how can these technologies be made more affordable and accessible within developing healthcare ecosystems like in India?
Okay, so are you thinking about how can we use this technology here in India? Yeah. Well, I'm not quite sure about how the digital technology has been used in India here, but it has been a lot of Indian doctors that visit our hospital and for some training regarding the digital technology. And during the discussion with them, I realized that actually in India, most of the dental clinics, especially in the big city, have been using the intraoral scanner a lot. And also they have been using the CAD/CAM technology, also the 3D printing to make the dental prosthesis. But I would say there must be like an education center or say like courses to teach more dentists to not just acquire the equipment because once you have the equipment, you have to know how to use it, and also the way I use these digital equipments is in a hybrid way. So like I'm not doing the cases in like the whole digital workflow. Sometimes I still do the traditional way. I still use the impression material to take the impressions because the intraoral scanner still has some sort of limitation. So you have to understand the limitation of these equipments and combine with those traditional technologies, and you can create your own hybrid digital workflow.
Dr. Nitin, with robotics and image-guided surgery evolving rapidly, how do we envision technology reshaping oral cancer surgery in the next decade while maintaining safety and cost effectiveness?
See, nowadays we have the technology has been very on very changed now. So for the cancer patients, we have a very good access. We can use a robotic surgeries. Then we have for AI based for resurfacing and remapping the tumor. This AI based is very good. And next is we have 3D printing. It's very this shows how much the tumor predicts size and color. This shows proper, and it makes sure that we safer margins are being prepared for that surgery. Then coming to 3D printing, in which we have a recon plates. We design a reconstruction plates according to the defect of the tumor, how much is the size of the tumor and how much is the defect. So the recon plates we can use exact accurate size from 5 mm to 7 mm for like mandibular defects we have. Segmental resection we do, so we can use their recon plates. Next is we have for cost effectiveness, we should always go for a good funding. That is one more thing important. And for in remote areas, like we don't have these facilities, so we should tie up with some main city hospital so that patient can get a proper access to the.
So Dr. Prakash, coming back to you, implantology now plays a major role in oral cancer recovery. So how can advanced reconstructive technology restore aesthetics and confidence? And what collaboration model works best between the prosthodontist and surgeon, me being a prosthodontist?
I guess implantologist is a boon to the dentistry. And that's true not only with the dentistry, with every field, like the facial refigurement, in case it be required after the resection. Post-COVID also, I guess, I have come across so many cases where the maxillectomy and mandibulectomy has been done. Once the patient is being diagnosed with oral cancers, the first priority is to get rid of the cancers at the earliest. And as we know that most of the cancers in the oral cavity, the first is squamous cell carcinoma, followed by verrucous carcinomas and other things. Post-resection, self-esteem and social integration is the priority of the patient. Once we get a resection, we always know that the patient always need a cosmetic, aesthetic demand and the functional demand. For that, our role comes in a priority as an oral surgeon, prosthodontist, as well as a general dental surgeon. We know that nowadays microvascular free transfer is there. Long years back, 20 years or 25 years back, there were more resection and the reconstruction with anything which is available. But now we are being tailored, we are catered. Before resection, we should know how to give a rehabilitation. So that's what the implant practice comes. With the microvascular transfer, there is a free fibula, there is anterolateral thigh flaps, there is radial freeform forearm flaps. With all these flaps, we are giving the patients at least the recovery, whatever we have resected. Not 100%, but more than 70%. With resections, we are giving maxillectomies, we are doing maxillectomies, mandibulectomies, partial alveolectomies, and with that, we know that the area would be irradiated, non-irradiated, and we all know that the irradiated areas having a less success as compared to the irradiated areas. So in that case also, if we consider the oral health related quality of life, with irradiated areas also, we have seen that we have given some kind of implants in the irradiated area after 1 or 2 years. Considering the patient's prognosis, not more than 5 years, we have given a quality of life so that he can eat. Nowadays, resection is being done and pre-surgical planning. As the modernization, we are doing a pre-surgical planning, and in case if the prosthodontist and the other specialist is being available, we can have a 3D printing, we can have a models where we can resect, we can tailor our resection so that once the resection has been done, the prosthetic rehabilitation can be done with the implants. Obturators can be given with the help of some kind of magnets, some kind of abutments, bar and clip attachments. The jagoma can be used for further rehabilitation in case we have done a maxillectomy and there is no more bone available, because the long implants can be placed in the jagoma. And with the help of that, we can stabilize prosthesis much better than the conventional implants. Even if we do not have the maximum part of the mandible, we can still use corticobasal implant as the primary modalities in those cases, and we can do an immediate loading with the help of the hybrid prosthesis. So pre-surgical planning is which is required with the modernization and multidisciplinary approach of a speech therapist along with prostho, oral surgeon, oncologist, and we can do a betterment for the patient for their cosmetic, aesthetic demand and the functional demand. We can also go for some kind of obturators and prosthesis in the nasal cavities, in the maxillary sinus, and obviously we can social reintegrate the patient with the help of the implants in the general day-to-day post-surgical recovery, so that patient can go out and have a social integration with the other people as well. Thank you, sir.
Thank you so much, sir. So, concluding this panel discussion, I would say that as oral leaders, we should not only be skilled clinicians, but advocates for prevention and community well-being. We should make sure that we conduct oral screening camps, school and workplace awareness programs, and collaborate with oncology centers. We should, of course, being an educator myself, make sure that we don't have isolated lectures on oral cancer, but bring a vertically and horizontally integrated model with linking oral oncology with pathology, medicine, and public health. We should also think about creating a culture of prevention, interconnection, and community leadership, as Dr. Bharat had told. And of course, utilization of AI, which can be a game changer for preventive oral oncology. With smartphone images, early detection can reach remote communities, as Sir had told, where specialists aren't available. So, I think as dentists, we need to take the stride forward, make sure that oral cancer, which is increasing day by day, needs to be started. We can start by utilizing the preventive measures rather than treating them after they become widespread. Thank you so much to all the panelists, and thank you for attention.
Thank you so much, sir. Thank you so much for that insightful panel discussion. Let's have a big round of applause for our wonderful panelists here. And before we proceed forward, I would like to invite Dr. Shetty to please come in center of stage and felicitate your fellow speakers for the session. Dr. Yong Chong Chen. Let's have a round of applause and, showcase our gratitude for this discussion. Dr. Nitin Bhagat. Dr. Major Chandra Prakash. Thank you, sir. Let's give them a clap, guys. Yes, thank you so much. I would like to invite Ms. Wanchen to please come on stage and felicitate our moderator for the session. Wanchen. Dr. Cheng, if you could please felicitate our moderator, Dr. Shetty. Thank you so much, Dr. Shetty, for this amazing moderation. Now let's capture this moment.